Hey guys, Nick here, and I'd like to start off this video by saying congratulations. No matter where you are in your board prep progress, you are learning more than you think you are. Stay positive, reward yourself, take deep breaths. Hey, speaking of deep breaths, let's talk about the respiratory system, starting with anatomy. The respiratory tree is anatomically and functionally divided into conducting and respiratory zones. The conducting zone begins at the nose and ends at the terminal bronchioles. Its function is to warm, humidify, and filter the air that we breathe. The bronchi are located in the middle of the conducting zone, roughly speaking. Now histologically, what might you expect to see here in the bronchi? Correct. Cartilage and goblet cells. Think of the trachea and bronchi as the first line of defense against any irritants you might inhale. The cartilage keeps the airway strong, while the goblet cells and glands secrete mucus in an effort to trap harmful substances. Now what can be found beyond the bronchi? Awesome, the terminal bronchioles, with pseudostratified columnar cells and smooth muscle. Now, why is this region called the conducting zone? Because it basically just transmits air. It's considered anatomic dead space, which means it does not participate in gas exchange. For example, if I take the train to go to work, I rely on the conductor of that train to get me there so I can do what I need to do. In a similar fashion, the air we breathe relies on the conducting zone as a mode of transportation so it can reach the respiratory zone and participate in gas exchange. To analyze the conducting zone from a different perspective, let's take a look at the left side of this image. Midline we see the trachea, and after the tracheal bifurcation we see the origin of the left and right main stem bronchi. Following the left main bronchus, we see that it will again bifurcate into smaller bronchioles, eventually forming the terminal bronchioles, seen here. Now, let's move to the right side of the image. I want you to first look at the columns titled goblet cells, glands, and hyaline cartilage. Now, as we discussed earlier, the goblet cells and cartilage are shown to be present in both the trachea and bronchi, but are absent in the terminal bronchioles. The glands will follow this same pattern as they assist in mucus production. Now, if you scan the entire image from left to right at the level of the terminal bronchioles, you'll see the only two columns still present at this level are the ciliated pseudostratified columnar cells, which extend to the beginning of the terminal bronchioles, and smooth muscle, which extend to the end of the terminal bronchioles. Again, the ciliated cells will help sweep out excess mucus produced by the goblet cells and glands just upstream. Now, what happens to these ciliated cells in smokers? Very good, they get damaged. This is why smokers are more susceptible to pulmonary infections than non-smokers. Okay, so what's the respiratory zone? Well, the respiratory zone is everything distal to the terminal bronchioles. It's made up of the respiratory bronchioles, alveolar ducts, and alveoli, and is part of the lung where gas exchange occurs. It's where inspired air goes to work. While most of the cells lining the respiratory bronchioles are cuboidal, the alveolar epithelium is simple squamous. This one layer of thin cells makes it an optimal environment for gas exchange to occur. The respiratory zone is a major site of pulmonary pathology, as we'll discuss later in this chapter. If tissue destruction were to occur here, the alveolar macrophages will do what they do best: clean up any debris and help out with the body's immune response. Flash quiz. Where are the pseudostratified ciliated columnar cells located? Answer: in the conducting zone of the respiratory tree, extending to the beginning of the terminal bronchioles. Pneumocytes are high yield for the board exams as they play a crucial role in both gas exchange and respiratory physiology. First, let's talk about type 1 pneumocytes. Type 1 pneumocytes make up most of the alveolar surface. Now, what's their cellular morphology? Now, these cells are squamous cells, the same ones we discussed earlier when talking about the alveolar epithelium. They are thin and flat, which make them great for gas exchange at the alveolar capillary interface. Type 2 pneumocytes are less abundant but are extremely important. This slide has been stained for surfactant, so the type 2 pneumocytes are actually showing up brown on histology to make them more easily identifiable. Type 2 pneumocytes secrete pulmonary surfactant from lamellar bodies, and it's the pulmonary surfactant which decreases the alveolar surface tension. Here's a little mnemonic for you. Type 2 goes with lamellar, and the 2 kind of looks like the double L in lamellar. Interestingly, these cells can differentiate into either type 1 or type 2 cells and are the ones that proliferate during lung damage. For example, in acute respiratory distress syndrome, also called ARDS, there is diffuse alveolar damage. The type 1 pneumocytes are the ones mainly affected simply due to their abundance in tissue. Once damaged, the alveolar membranes become permeable and a protein-rich fluid leaks into the alveoli, eventually forming the classic hyaline membrane seen in this condition. However, it's the type 2 pneumocytes that will begin to proliferate in an effort to regenerate both the type 1 and type 2 cell populations. This concept of tissue regeneration after a pulmonary insult is commonly tested on the board exams. What other lung cells are important for you to know? How about Clara cells? These are non-ciliated columnar cells with secretory properties. Where are they found? Well, they're found in the bronchioles, not in the alveoli. They protect the bronchial epithelium by secreting a surfactant-like solution and degrading toxins via what pathway? Correct, the cytochrome P450 pathway. Now coming back to this image, I now want you to focus on the Clara cells column only. Again, we see that the Clara cells are present only in the bronchioles and terminal bronchioles, but not the alveoli. Think C for Clara and C for conducting zone, the area that these cells remain in. Okay, now let's get back to surfactant. So I said a little earlier that surfactant is secreted by type 2 pneumocytes. Now what's the main component of surfactant? It's mostly made up of a phospholipid called dipalmitoyl phosphatidylcholine, which allows for surfactant to decrease the surface tension in the alveoli. According to the law of Laplace, the collapsing pressure equals 2 times the surface tension over the radius. I think it's also helpful to sketch out the relationship for yourself. Looking at this equation, we see the collapsing pressure will have a linear relationship with whatever changes occur in the numerator, which is in this case surface tension. As surface tension increases across the alveolar epithelium, the alveolar collapsing pressure will also increase. In contrast, the collapsing pressure will have an inverse relationship with whatever changes occur in the denominator. As the alveolar radius decreases, say during exhalation while air moves out of the alveolus, the collapsing pressure will rise, predisposing that alveolus to collapse. So, what's the bottom line? With surfactant decreasing surface tension, you should see an increase in lung compliance and a decrease in work of breathing because more alveoli remain open at the end of a breath, and if they do collapse, it requires less gas pressure to reinflate them. Finally, surfactant synthesis is a major part of fetal lung maturity. Later, we'll talk about neonatal respiratory distress syndrome, which is where you don't have enough surfactant at birth for efficient respiration. Any idea how you'd treat this? Awesome. Maternal steroids prior to birth. The glucocorticoids help to expedite fetal lung maturation and are most effective if administered to the mother once it's known that the child will be born premature. Understanding the anatomy of the lung, particularly the relations between different lobes of the lung, has radiographic and clinical significance, so you're going to see this on the boards. The lungs themselves are actually made up of smaller units called bronchopulmonary segments. Just like any other organ in the body, the lung needs a blood supply of its own that will deliver oxygen to the pulmonary tissue itself. Blood is delivered to each bronchopulmonary segment via a bronchial and a pulmonary artery, which run in the center of the segment. The venous blood and lymphatics are drained along the edges of each segment. This is how the lung receives oxygen necessary to perform properly. For some reason, board exams commonly ask you on the relationship of the vessels to the airway in a bronchopulmonary segment. So please be sure to remember that the arteries run in the center and the veins and lymphatics run along the edges of each segment. Now, what do the lungs look like grossly? The trachea divides into right and left mainstem bronchi, which serve the right and left lungs respectively. One board-testable fact is that the right mainstem bronchus takes off from the trachea at a more vertical angle than the left bronchus. How do you think this anatomy affects intubations and aspirations? Well, if an endotracheal tube is advanced too deeply, it's more likely to go into the right mainstem bronchus. Also, foreign body aspirations are much more likely to be found in the right lung, specifically the lower lobe, due to the vertical angle of the right mainstem bronchus. The right lung consists of 3 lobes, while the left lung has 2 lobes and a lingula. One piece of anatomy that is unique to the right lung is the presence of the horizontal fissure. This fissure, which separates the superior and middle lobes of the right lung, lies at the level of the 4th rib anteriorly. On a board exam, the question stem might describe a knife wound to the anterior chest, then ask you what lung lobes have been affected based on what rib level the knife is at. Knowing that the horizontal fissure is at the level of rib 4 and knowing what lobes it separates will help you rule out some of the answer choices. In the left lung, the lingula is the homologue of the right middle lobe, but this space in the left lung is occupied by the heart. Lingula is Latin for little tongue, so this area is sometimes referred to as the tongue of the lung. It's best to consider the lung from several angles. As you can see, looking anterior to posterior, the inferior lobe of the right lung is mostly obscured by the superior and middle lobes, suggesting a more posterior position of the inferior lobe. The left lung demonstrates the same relationship, with the superior lobe being slightly more anterior than the inferior lobe. In terms of lung borders, on the front of the chest, the apices of the lungs extend 2 to 4 centimeters above the clavicles. On an exam, the question stem could describe a penetrating lung injury to the region just superior to the clavicle. The patient could be experiencing tachypnea, tachycardia, and diaphoresis. With these symptoms, you must consider damage to the lung apex. Clinically, this region must carefully be approached when inserting a chest port, as the operation is done just along the clavicle within close proximity to the lung apex. On the back, apices extend to T1, and the base of the lungs extend to T10 on exhalation and T12 on deep inspiration. So if you do a needle thoracentesis to drain a pleural effusion, where are you going to end up? Well, the location may vary a bit, but generally you'd insert the needle in between the 5th and 7th intercostal space anteriorly, the 7th and 9th intercostal space in the mid-axillary line, and in between the 9th and 11th intercostal space posteriorly. Okay, let's put this clinical knowledge to use. So, what lobe is the pneumonia in this picture? Well, it's on the right side, so how many lobes do you have to choose from? Correct, 3. You can also tell it's not the right upper lobe because that area is completely clear. You can clearly see the right hemidiaphragm, meaning that it must not be in the right lower lobe. Therefore, it must be in the right middle lobe. You can also tell that it's in the right middle lobe because of how well it follows the horizontal fissure and fades inferiorly. In contrast, this is a right lower lobe pneumonia. Here you cannot see the diaphragm at all, and the superior lung space looks clear. From a surgical and radiographic standpoint, there are several important structures that perforate the diaphragm at different levels, and lots of mnemonics you can use. The inferior vena cava, or IVC, passes through the diaphragm at T8. The esophagus and vagus nerve penetrate at T10. And the descending aorta, thoracic duct, and azygos vein enter at T12. Remember this, I ate 10 eggs at 12. The diaphragm is the primary muscle of respiration. This muscle is innervated by the phrenic nerve, which comes off of C3, C4, and C5. Remember, C3, 4, 5 keeps the diaphragm alive. If the diaphragm is irritated, where will the patients report pain? Correct, in the shoulder and trapezius ridge. Now what kind of pain is this? This is referred visceral pain. For example, an inferior wall myocardial infarction might present atypically as shoulder pain. The infarcted myocardium sits on top of the diaphragm and will irritate the diaphragm surface, thus referring pain to the shoulder and trapezius ridge. A 3-year-old boy is brought to the hospital with acute shortness of breath. He was playing with marbles in the playground when his mother noticed him cough and become acutely short of breath. As the boy was continuing to struggle to breathe, he was brought to the hospital. Prior to this incident, he was healthy. His vaccinations are up to date and he takes no medications. On X-ray of the chest, which portion of the lung is most likely to appear abnormal? The answer is right lower lobe. Acute shortness of breath in young, healthy children is most often due to aspiration of small objects. The right main bronchus is more vertical and wider than the left, and aspirated particles are more likely to lodge at the junction of the right inferior and right middle bronchi. If the object aspirated is radiopaque, like a quarter, which is very commonly aspirated, then you'd be able to see it on a chest x-ray. Well, that's it for respiratory anatomy. Just remember, in through the nose and out through the mouth. You're almost there.